tuning in to this live. Today, on behalf of Professional Helps, I, Bhagat Srinivasan, am going to have an important interaction with today's guest, Dr. Vijayalakshmi, MD, DVL, who is an Associate Professor of Villupuram Medical College. Thank you for being with us here today, ma'am. And today's topic in light of World Psoriasis Day is psoriasis. Now, a brief intro on the topic. It is an autoimmune disorder with a lot of social stigma attached to it. This is due to lack of knowledge by practitioners and its undertreatment as it is considered hard to control. Today, we hope to make it a little bit simpler. At the end of the session, you are free to put in all your doubts and I will select them and ask ma'am. So ma'am, I would like to begin with the first question. Now, psoriasis is kind of a dim-like term. Is it contagious?
Okay, first let me tell you about the psoriasis. Psoriasis is Greek terminology. It literally means itching. But there is no connection between itching and psoriasis. So if I have to define psoriasis, it is an autoimmune disorder with genetic predisposition, which you can see mostly on the extensor aspects and characterized by erythematous red scaly plaques. Okay, this is the definition of psoriasis. So there is no itching at all in psoriasis. Since I already said it's a genetically predisposed condition, it is not a contagious disease. So it comes mainly as an autoimmune disorder.
Thank you, ma'am. Okay, second question. The etiology of the disease, what do you think is the most common cause of psoriasis?
Okay, see, psoriasis is a multifactorial skin condition, usually occurring in people with genetic predisposition. Okay. If I have to make it very, very clear, in what you see actually in psoriasis is there is hyperproliferation of keratinocytes. Okay, so there is the cell doubling time is very much decreased. Usually, cell cycling time is 28 days, whereas in psoriasis it doubles up even within 3 to 4 days. That is why you see a lot of silvery scales and flaking all over the body. So this is what happens. See, why this happens is because of the increased circulation of cytokines. Again, these cytokines are secreted by activated T cells. So these T cells, mainly these memory T cells, are formed in certain individuals with HLA predisposition, like these forbidden clones, which you have already studied in your microbiology. So due to some reason, there is a molecular mimicry between these keratinocytes and the memory T cells. So it actually fights with your own body keratinocytes and causes a lot of damage. So this is how the psoriasis this is the pathogenesis of psoriasis. So if you see the etiological condition, it is mainly a genetic predisposing condition. But this genetic predisposition will be triggered by certain environmental factors. So the first environmental factor which we see commonly is any infection. Whenever you have streptococcal infection, it triggers these T cells. There is a molecular mimicry, and again it fights with the keratinocytes, and there is increased proliferation. Other common condition is stress, trauma, certain drugs like NSAIDs, people who take alcohol, who smoke a lot. All these people also have a predisposition to develop psoriasis.
Ma'am, now that you mentioned these predisposing factors, if you're going to take ethnicity as a particular predisposing factor, is there any ethnic group which is particularly predisposed to this disease?
Okay, before going into ethnicity, we'll see the epidemiology of psoriasis. So the incidence of psoriasis worldwide is about 2%. Okay, so ethnicity means in which kind of population you see lots of psoriasis. Usually it is the white people or Caucasians. So commonly we see psoriasis in those type of people. Next common people that we see is Afro-Americans. Not Africans, it is Afro-Americans, probably because of the change in their lifestyle once they have left the continent and they have gone there. Then you see a lot of this predisposition in Hispanics, that is people from Spain. So this is the ethnicity.
So it is towards more of the Western hemisphere, you would say.
But all over the world, it is about 2%. Even in other Asian countries also, you see. The general distribution is about 2%.
Sure, ma'am. Okay. What are the signs and symptoms of this disease, ma'am?
Okay. Sign is what we see and symptom is what the patient complains. So we'll go into this. Okay. Usually the patient will present with red lesions. So they will say it is a rash, which is flaking, that is scaly and mostly distributed on the extensor aspect. Sometimes you will have similar lesions on the scalp also. Sometimes they'll have pitting in the nails. Some will present with severe arthritis. That is also one of the manifestation of psoriasis. Some will have inflammation of the whole body. This is called erythroderma. So these are the signs with which they will present. And as you said, itching will also occur in few people. If it occurs, it is a bad connotation. It means the patient is going in for severe kind of psoriasis, which is called erythroderma. Okay. Coming to the signs. See, what we commonly see, that is, as a physician, you are supposed to look for two signs. So you would have heard in your junior classes also. One is called auspich sign, and another one is called candle wax sign. Now, auspich sign, when you grade the lesion with a slide, you will see multiple pinpoint bleeding. That means that the epidermis has thinned out and the papillary dermis is jutting into the epidermis. So it is called auspich sign. The other sign that you see is candle wax sign. Because of the thickened stratum corneum, when you scratch with the slide, you will feel like as though it is a candle wax. These are the two signs with the physician's elicit in a case of psoriasis.
Okay. Thank you, ma'am. Now, the fifth question being, you talked about itching, right? And itching is a sign that the disease is progressing and becoming more severe. Could you explain a little bit more about this, and especially the difference in intensity? Apparently, it is going to increase during the night. Is it so?
No, usually psoriasis never itches at all. Okay.
Okay.
So, then for these ugly rashes, it is an asymptomatic condition. So, a lot of social stigma. If itching is present, only it denotes two things. That is, it is going in for erythroderma, that is worsening of psoriasis. And there is a very rare condition, follicular psoriasis. I mean, it is not reported worldwide. I mean, about 25 cases have been reported where the psoriasis is present only in the follicles, opening of the hair follicles. That is very, very rare. So only in these two conditions you have itching. Otherwise, it is asymptomatic and there is no nocturnal itching and any other type of itching or pruritus associated with psoriasis.
Okay. Now, you had previously mentioned that stress can also, increase it, right? Is there any proper linkage between psoriasis and stress?
Yes. When you have lot of stress, again, this endorphins, which are secreted by the brain, level is decreased. And there's a generalized inflammation all over the body. Again, as I said, some of these interleukins, 17, 23, 12, all the amount of secretion is very much increased. Again, this will give rise to lot of epidermal proliferation. So this is the link between stress and psoriasis.
Okay. What are the complications of this disease, ma'am?
Okay. So one of the most important complication is stress and depression. So mostly when you say a patient is having psoriasis, they go in for anxiety. They are very much depressed. And most of them even don't do their regular activities. So they have a poor quality of life. Okay. Again, to go into details, again, we have another scale called DQLI, which will not go into it today. So many of these people go in for alcoholism. They take drugs and they go in for alcoholism. They get withdrawn. So this is the one of the important complication of psoriasis which we have to address, and that is why we are celebrating. We are honoring this day with psoriasis so that you can have a free skin. Even patients with severe psoriasis also can live a very happy life. So that is the stress. That point I want to stress today. Okay. So this is the one of the important complication. Other complication is psoriatic arthritis. Few people will have same issues in the pain in the joints also. Some will go in for erythroderma. Some will go in for other complications like usually obesity. So when you have stress, again, people tend to eat a lot and they get stressed. And there is one more association between psoriasis and heart disease. Most of these people have increased risk of developing heart disease, and there is another syndrome called metabolic syndrome. So usually people with psoriasis go in for this metabolic syndromes. These are the commonest complications which we see in psoriasis.
Sure, ma'am. Is there any way this can actually affect the CNS? Like you've mentioned that predominantly CVS is under effect. Similarly, do you think it has any implications on the CNS?
So as I said, directly there is no connection between psoriasis and CVS. Okay. Due to lifestyle modification, you can have a cardiovascular problem. Similarly, psoriasis also directly doesn't affect CNS. Okay, there is generalized inflammation. See, body have lot of cytokines circulating all over the body, and there is generalized inflammation. This inflammation can cause inflammation of the neural tissues also. So due to that, there can be development of Parkinsonism. As you all know, Parkinsonism is not curable; it is only controllable. This way, there is an indirect association, not a direct association between psoriasis and CNS.
Sure, ma'am. Okay. What are the current treatment modalities for this disease, ma'am?
Before going into the treatment, we'll just separate psoriasis into two types for treatment purpose. Area of the involvement less than 10% and more than 10%. If the area of involvement is less than 10%, we go in for a treatment called topical therapy. That is applying something on the skin itself and directly curing the disease. If it is more than 10%, they go for systemic therapy. So in topical treatment, commonly what we use is steroids. Okay. So in this condition, usage of steroids is very much advisable and it is quite safe also. So what does the steroid do? It reduces the inflammation. Once the inflammation is reduced, the skin becomes normal. See, because of the side effects of steroids, we are no longer using steroids so often. We go for other alternatives. Like commonly what we use is called tacrolimus, which is a calcineurin inhibitor. This again drives away all the T cells from the skin and it helps to reduce the inflammation. Okay. There are certain other topical treatments also. Commonly what we use is retinoids. Tazorotene is commonly used. Here also rapidly proliferating keratinocytes are getting controlled and we get some relief in psoriasis. Then we use topical vitamin D analog called calcipotriol. This also to a certain extent reduces the proliferation of your keratinocytes. Some of the other things which are not used so often are coal tar and diethylenol. These were used in the past. Nowadays, we don't use it because it leaves a lot of stain that causes a lot of skin irritation. Here again, the target is on epidermal proliferation. So these are the topical therapies that we are using. Going in for systemic therapies, what we commonly use is your steroids. Sometimes steroids have to be given. There is a lot of inflammation, but there are other alternatives also. What we use is anti-metabolites. So the main target here is your T lymphocytes, which these T lymphocytes only target the epidermal cells. So we have to control the T cell population. So most of our anti-metabolites will target the T cell population. So what we commonly use is a methotrexate. So this will reduce the proliferating T cells. Again, what we use, another drug that we commonly use is cyclosporine. Then the recent drug is apremilast, which is a phosphodiesterase inhibitor, which also reduces the T cell population. These three drugs are commonly used, and sometimes, as I said, steroids will be used if there is condition is very, very severe. There is no such thing as sparing the use of steroids. That is the it is a rescuer. In case you have to use steroids, you should not hesitate. Okay, so you have to use steroids simultaneously and then use all the anti-metabolites simultaneously. Then there are other minor drugs we use sometimes to patch up the gaps, like your mycophenolate mofetil, azathioprine. All these drugs are also used. Okay, this is systemic therapy. All these are all anti-metabolites. Then we have a very nice therapy called phototherapy. Okay, we use ultraviolet light, and with that we drive away the T cells from the dermis so that the epidermal proliferation is reduced and cytokine level is also reduced. Okay, so there are two types of ultraviolet lights that we are using. One is A and B. The wavelength of B that we commonly use is P11 to 310. That is called narrowband UVB. It is one of the most safest therapy. Okay, we can use it for pediatric age group also. Then the other therapy that we use is UVA, where we use 300 to 420 nanometers for driving away the T cells. But the only problem is when you use UVA, you have to give soralin, some other drug, which will activate the T cells along with UVA. So this is a very novel therapy which we very recommend for most of the people all over the world. Then you have some recent therapies. These are all called biologicals. Okay, these have developed in the recent years to treat people with comorbidities. Like for example, a patient will be having hypertension and psoriasis. If you use an anti-metabolite like cyclosporine can cause hypertension. So you have to use some other drug. So these are all biologicals which can be used at these peculiar conditions. Okay, so biologicals are drugs which are usually fusion proteins or monoclonal antibodies which are targeted against these cytokines. So when you use monoclonal antibodies or these fusion proteins, they will directly go and inhibit the cytokines, and they don't have much of a side effects like the anti-metabolites that we used. So if we go into the details of the biologicals, I'll tell you about few drugs which are using. So commonly what we are using is etanercept. Okay, this is a TNF alpha receptor antagonist. Then we use TNF alpha cytokine. Another biological called ustekinumab, which is interleukin 17 antagonist. Then you have secukinumab. All these are all recent biologicals which we have been using in the recent past, when we have got very good results. Okay. These are the few recent treatments that we are giving for psoriasis.
Sure, ma'am. And coming to the last question, but also a slightly important one. What are the prophylactic measures? Since you've told that there is no permanent cure, and I would like to ask more about that too, but what would be the prophylactic measures which you could take for this disease and manage it, ma'am?
Okay, so now we do a lot of genetic counseling, so that has to be emphasized. Okay, if there is a history in the family, then getting married between two people who have similar history should be avoided. Okay. In case you have the patients, like we ask them not to take to alcohol, not to take to any smoking, and reduce stress by lifestyle modification. We ask them to do meditation. We can ask them for doing regular exercise. We can ask them to do yoga. Then there are certain drugs that has to be avoided. Commonly, these NSAIDs or painkillers that we give can cause inflammation and can give rise to psoriasis. So these people should avoid. It is not absolute necessity. You can avoid taking those drugs. Okay. Then you have some drugs like anti-malarials. These drugs also should not be taken. We have so many alternatives that can be taken. Antipsychotic drugs like lithium also should not be taken by these people. So these are some measures that we can take if they have the predisposing factors or predisposing genetic condition to avoid psoriasis. Okay, once you are diagnosed of having psoriasis, then you have to take counseling. Like that is why the psoriasis day is also celebrated, to say it is nothing and you can lead an absolute normal life. So you have to counsel them and tell them all about the lifestyle modification, to eat healthy, have a good food, do regular exercises. They can consume lot of HH omega. This is essential fatty acids which they can consume. This also is supposed to reduce cytokine level in the skin. This is also supposed to keep the skin healthy. These are some things that we can do to have a healthy life.
Sure, ma'am. And is there any leading research which is right now going to bring in about a phenomenal amount of change? Is there anything working on that? Is anyone working on that right now?
Pardon me, can you repeat the question?
No, ma'am. I'm asking, is there any current research which is like near a breakthrough, which can provide a significant change in the way this disease is being, progressing, how it's progressing? Is there anything which is coming up, like either treatment-wise or understanding it, anything new about the disease?
Much of research is going only into this genetic studies. So, see, as I said, multifactorial conditions. Yeah, I said one HLA which is commonly associated with psoriasis. There are so many other genetic foci also which is associated with psoriasis. Once we decipher this genetic foci, then we will be near the. Okay, we have gene therapy and so many other therapies coming. So we can use one of them to avoid psoriasis. Now, the other thing is, as I said, biologicals. There are so many new biologicals which are coming up, which have got least side effects and which cures even in 1 or 2 shots of injections. So much of research and money is going into this development of this latest biologicals.
Sure, ma'am. Okay, now, ma'am, I'll just go through the questions which they've posted up till now, and we will answer them. Okay, so people have asked, what is the difference between psoriasis and eczema?
Psoriasis and?
Eczema, ma'am. Okay.
See, psoriasis is a genetically mediated condition, and it has got some genetic foci, in particular chromosome, which will cause psoriasis. But whereas eczema, you don't have such predisposition at all. It's an entirely local condition where you have just inflammation of that place alone, and we don't know who will have eczema and who will not have eczema. What we have recently found out is some alteration in the sympathetic and parasympathetic nervous system in that particular area, which is giving rise to eczema. So these are two entirely different things, and even though they look similar, you can find out by so many signs that I've already told you. Like I've already told you about this auspic sign and candle wax sign, which will be very much missing in eczema. And this eczema also will present as three different forms. One is an acute eczema where there will be a lot of oozing. Then you have a subacute eczema where there will be scaling also. The chronic eczema, there will be only thickening of the skin and itching. Okay. So predominant sign in eczema will be itching, whereas in psoriasis you won't have any itching at all. So symptoms wise also you will be able to differentiate between psoriasis and eczema.
Sure, ma'am. Yes, ma'am. Then the next question is, does psoriasis run in family? Like, does it run down in the family?
It runs in families. Okay. There is 30% of chances of the children developing psoriasis if the parents have psoriasis. I mean, either one of them have psoriasis. If both of them have psoriasis, the chances of children developing will be 50 to 60%.
Mm-hmm. Another question is, do you see any changes in psoriasis, like taking pregnancy as a condition? Is it possible for a pregnant woman to get psoriasis? Do you see any different features in it? How will it affect a pregnancy?
Yes, definitely the psoriatic picture in pregnancy will be different. Okay, so what we will commonly see is pustular type of psoriasis, and it will be present all over the body. Okay, so sometimes that can give rise to preterm deliveries, or if it is in the early condition, you can have loss of pregnancy, a miscarriage also. So the picture will be totally different in when a psoriatic woman becomes pregnant, or when a women with predisposing factors become pregnant also, there is a chance of the girl becoming psoriasis, getting the psoriatic symptoms.
Okay. And I have a question, ma'am. You told that this is associated with the factors of inflammation and cytokines. I have heard of a term called cytokine storm. Can that be associated with psoriasis?
See, cytokine storm is a reaction to any infection.
Okay.
So HIV also we have similar condition where you develop a condition called iris. Okay. So even in leprosy there is a condition called type 1 and type 2 reaction, which is again an inflammatory condition developing as a result of infection. Okay. But here it is not cytokine storm. The epidermal cells, the milieu of the epidermal cells will be bathed in the cytokines. Okay. There will be a lot of interleukins circulating in and around the epidermis. Okay. That will cause proliferation, and there is no storm. Okay. So this T cells, which are these forbidden clones, which should have been eliminated in the thymus or in the spleen level itself, will be in the circulation when there is an antigen which stimulates the keratinocytes. Have a similar molecular mimicry, like if it has the same molecules present in the antigen, these keratinocytes will be considered as antigens by the T cells, and they will directly go and attack the epidermal cells. This is the cytokines that is going around, and these keratinocytes will be bathed in the cytokine. That is how it is getting affected. Whereas the cytokine storm is an entirely different condition. That is a protective mechanism. Okay, here only a set of T cells is producing the cytokines. There it is all over the body. All the T cells will be producing the cytokines to counteract the viral infection. Okay. So it is only the people with that particular HLA predisposition having that particular memory T cells will be activated, and it will be fighting with the keratinocytes because of the molecular mimicry between this and the streptococcal Ts. Whereas there, the whole body will have T cells, and the whole body will be producing inflammation, and they will be fighting with all the organs in the body. So these are two entirely different things. Okay, that is an infection, and this is an autoimmune disorder.
Sure.
I think you got the point.
Next question is, what is psoriatic arthritis?
Okay. There is an inflammation all over the body. Okay. So if it is happening in the skin, it is psoriasis. If the same inflammation occurs in the joints, you get what is called psoriatic arthritis. The risk of a psoriatic vulgaris patient going in for arthritis is about 5%. Okay, if you see him with nail pitting, the chances of him going in for psoriatic arthritis is about 2%. So the same inflammation which occurs in the skin will occur in the joints, and most common joint that gets affected is your small joints, and next to that you will see your knee joints. Very rarely even your spine will get affected. Okay. So this is psoriatic arthritis.
Okay. Is there any particular diet plan we should stick which can aid in preventing or at least reducing the amount of psoriatic lesions which we get?
Avoid taking alcohol. That is one restriction. You can take lot of food contain HH omega fatty acids. You can take lot of fish also. Fish also contains lot of this HH omega. So this is also helpful in taking care of your psoriasis. Of course, your regular vitamins, minerals. You can take lot of fresh fruits, vegetables. All these are supposed to help help in recovery of the skin. And they say even red wine can help you to have a very healthy skin, for especially psoriatic people. They recommend in red wine and in normal levels. Okay, can help people with psoriasis.
Okay, and I just have two more questions before we end the live. One is about the possibility of recurrence of the disease in treatment when you withdraw the drugs. Will the disease recur again with an aggression, or will you be able to stop it at that level?
See, I said it is an incurable disease. It can be controlled. You can have a very normal life. You can have a very normal skin. There is no such thing as withdrawing. Okay. You have to have an eye on the patient. Maybe we can reduce, say if I'm putting the patient on cyclosporin for say about 2 or 3 months, I can reduce the dose of cyclosporin, or I can replace cyclosporin with another drug like methotrexate or least harmful drug like apremilast. There is no question of taking away the drug. Okay. If it is a very small plaque psoriasis, see on the fingers or on the toes, then we can give topical treatment and wait for it to resolve. Then when the whole thing resolves, you have to have an eye on that place. When there is a mild recurrence also, we should apply the cream. There is no such thing as withdrawing the whole treatment. Okay. So there is no question of suddenly withdrawing the treatment also. Okay. If you suddenly withdraw, then there will be a recurrence. It will come back in full-blown condition. So we have to gradually withdraw, and as the symptoms reduce, we can reduce the amount of drugs also. And always watch the patient or have a surveillance over the patient throughout his life.
Sure. And to cap out off with the last question from the audience is, does animal protein trigger psoriasis? Like, is there any particular... No, you said that actually, for example, you said that fish is good because it contains high amount of omega fatty acid. Similarly, they've asked it, does animal protein trigger psoriasis?
It doesn't trigger psoriasis. Generally, we say animal protein you should avoid because they have lot of fat and other things also associated coming along with animal protein. Otherwise, these animal proteins are quite good. If you have to take only the protein part from the animal, it is okay. But when you consume it with lot of this associated fat, then again there is a increased risk of hypertension, cardiovascular problem, obesity. That is why we say avoid animal proteins. Otherwise, there is nothing against it. In fact, in psoriatic erythroderma will be losing lot of proteins because of the increased scales. Will be losing lot of proteins, and there are times when we say you have to take high amount of protein diet also. Not for normal psoriasis and certain conditions.
Okay, ma'am. And now, before we end the live, I'd like you to give your comments on World Psoriasis Day and what you would like to end the live by saying.
Okay, like I said, since the distribution of psoriasis, worldwide psoriasis, about 2%. So if you take 100 people, 2 of them will definitely have psoriasis. What we have to do is counsel them, accept them, keep motivating them, keep telling them it is a general, like it's like any other disease like hypertension or diabetes, where you have to keep taking medications for a long time. Another thing that I would like to tell is it is not contagious. Okay, years together, if you sit next to them, have food with them, it will not spread to you. Okay, so we have to accept these people, motivate these people to take regular treatment and help them to lead a very normal life. So the thing that I want to emphasize is we have psoriasis. The aim of the treatment or the aim of the patient or aim of the whole society is to have an absolutely normal skin and we lead a very good quality of life.
Thank you, ma'am. That was a wonderful discussion with you. I'm really, really happy that I could have this discussion, and it was really informative. There were some things which I really didn't know.
I'm also very happy to meet all young people. I'm looking more for interesting events. Thank you so much for giving me this opportunity.
Thank you. Okay, guys, thank you for attending this live. It's time it comes to an end. Thank you.